Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
Hello and welcome. Thank you for joining us on The View on GU. We are live from ASCO in Chicago. It's Monday, essentially wraps up GU day today. Chris, time to talk about prostate cancer. How's ASCO been so far for you?
Oh man, ASCO's always good. It's sometimes it's a bigger day-to-day and sometimes it's a bit more on the social and networking side. And I think we've had a great opportunity to connect with colleagues across the world, and it's always a great chance.
I think it's fair to say we're going to test our chops with covering prostate today, and certainly we've enjoyed all aspects of it. But let's dive right in because we've had some very interesting late-breaking abstracts and some good Canadian content throughout the prostate session. So let's start with what's called the MAST study. And just to set it up for our listeners and viewers, this is a randomized, double-blind, placebo-controlled trial of metformin in reducing progression on men with really low-risk prostate cancer. And for those who perhaps don't treat this disease, there are options of management, which include watchful waiting, active surveillance, and definitive therapy. Metformin's been around for a while, lots of attempts in studying it. Chris, take us through this trial and why it appears urologists are so interested in metformin as an adjunct to other therapies for prostate cancer.
Absolutely. And so this is a trial that is a little near and dear to Canadians. I think it's most Canadian centers contributed. And I certainly remember being a resident in clinics in Toronto and putting patients on trial. And so I think we need to take a little step back and look at the context here. We're talking about low-risk prostate cancer. So in general, guideline recommendations here are for active surveillance. We're trying to avoid the harms of active intervention with local therapies like surgery or radiation for these men, while still preserving cancer control opportunities and the opportunity to intervene in the future if the need arose for oncologic reasons. And so when you're in that space where someone has cancer, you don't think it's a particularly aggressive cancer, there's always that desire to do some secondary prevention, right? To try and reduce that progression risk. And so there's a lot of studies that have been done here, right? 5-alpha reductase inhibitors have been tested in clinical trials. The MEAL study looked at some dietary interventions here. And so metformin in the MAST study is sort of the latest foray into this whole treatment paradigm. And I think, there's a good rationale as to why you would want to design this study. We'll get to the results, and obviously they don't pan out quite the way we hoped. But metformin has a strong preclinical and epidemiologic rationale as a sort of anti-cancer agent. It certainly, from a biological or preclinical perspective, affects proliferative pathways in a way that is beneficial, and also affects the immune microenvironment in ways that we might think have oncologic benefits. And there's a lot of data that's come out of Toronto, but also a lot of other places looking at the effects of metformin in epidemiologic studies on men with prostate cancer. And the issue here obviously is that these are men who are diabetic and receiving metformin for a specific diabetic-related indication. And so that introduces some unknown confounding by indication and selection biases that we have a hard time wrapping our heads around. And that's why I think really there's this real benefit to having the confirmatory or randomized data. And so just to sort of walk through the MAST study, this is a good pan-Canada effort, about 400 men with low-risk prostate cancer. And this is really enriched for a very low-risk phenotype. And so these are men who have low-grade prostate cancer, Gleason 6 or lower. They have a small number of cores involved, so less than 1/3 of the cores, and 10-core biopsy was mandated. So we're really talking here, many men are going to get 12-core biopsies. So we're talking, less than 3 or 4 cores on average, and less than 50% of the maximal core involvement. So this is low volume, low grade prostate cancer. Men also had to have a PSA under 10. And so this is really in that sweet spot for men who all guideline bodies would say definitive management is overkill here, and active surveillance is the preferred approach. And so these men were randomized 1-to-1 to receive metformin for 3 years or placebo in addition to the standard surveillance protocols. And the primary endpoints were aggregated in a composite endpoint, but it looked at pathologic progression and clinical progression as indicated by the need for definitive intervention. And it's important to step back and remember what active surveillance entails. This is not just watchful waiting. We don't just leave people alone and ignore their disease. And so this, both within clinical care and within the context of the trial, mandated some repeat biopsies at 18 and 36 months and clinical evaluation throughout. And so I think those are pretty consistent with the way we practice surveillance today. Obviously, omitting the MRI component that I think is a key component of our care. And so, the overall takeaway, I think, is really a bit disappointing, but we see almost completely overlapping KM curves, really no effect at all, an unadjusted hazard ratio of 1.08, p-values of like 0.6. If you look at their aggregate for progression, pathologic progression, very equivalent, therapeutic progression, the event rates were lower. But if anything, it actually flipped and there's more therapeutic progression in the men who are receiving the metformin. And I think, overall, this tells us that in this patient population, metformin is not going to, help us maintain men on active surveillance for longer. And there's two important subgroup signals that I think actually even highlight that message even more so. And so number one, when we think about pathologic progression, the authors looked at any of a higher number of cores, greater involvement of any one core, or upgrading. And importantly, they looked at upgrading both as Gleason score 7 or higher, starting with Gleason 6, or Gleason score 8 or higher. And there was a higher rate of men in the metformin arm who are found to have Gleason 8 or higher on their subsequent biopsy. So this was 13% versus 4.5%. This didn't reach statistical significance, but it kind of fits with that 5-ARI story again, where we saw that it wasn't impacting overall cancer rates, but there's that signal that the intervention actually led to worse or higher rates of the more aggressive cancer phenotypes.
What do you make about that group that by BMI?
Yeah.
Okay, so there's less than 30 or more. It looked like the less than 30, really no difference, unadjusted hazard ratio 0.82, but the BMI 30 or more, the unadjusted hazard ratio 2.39, essentially showing metformin treated patients did worse in terms of pathologic progression. The tests for interactions all appeared unadjusted or adjusted to be, significant. What do you make of that?
Yeah, it's an interesting data point. I think it's a bit unexpected. I think it's important to understand the inclusion and exclusion as we look at this. So these had to be men who did not have an indication to need anti-diabetic therapy. So any prior diagnosis of diabetes or indication that you might need it was an exclusion. And obviously, obesity rolls with impaired glucose tolerance. And so they had an A1C cutoff in the inclusion criteria as well. And so I think it's a little bit hard to understand what obese men with normal glycemia means as a sort of metabolic milieu and what that looks like. Certainly, it gives us pause. And I think overall, there's going to be need for a little more digging into these data, but really, I think should quiet some of our enthusiasm on metformin. I know certainly even outside oncology, there's anti-proliferative notions and the idea that there may be an anti-inflammatory or anti-proliferative effect that may affect longevity. And I think when we do these rigorous trials, it's a little word of caution for people who are taking metformin outside of standard indications. Obviously, it's a good drug if you need it for diabetes, but outside those fixed indications, I think this is a word of caution.
Yeah. I mean, maybe we've cooled on metformin in this setting. Certainly doesn't look like it improves, how we look after men in this kind of low risk prostate cancer setting. So that's probably a good pivot to now look at what another late breaking abstract was. And let's talk quickly through Charted. This is Charted 2, again, building on the original Charted data. I remember this coming out when I was a medical oncology resident. It was all the rage to give docetaxel for MCSPC as a monotherapy. This was the second kind of build on, again, planned some time ago to look at what we could do next. And so essentially, these are for patients who would have progressed on a Charted-like protocol. So ADT plus DOSI for MCSPC, who then would have needed treatment. And these patients got randomized on this trial to a control arm of abiraterone, which is prednisone, very reasonable control arm, to an intervention arm that had also abipret along with cabazitaxel, and this was dosed at 25 milligrams per meter squared for up to 6 cycles. PFS is a primary endpoint, and really I would say an important trial at the time. When we look at the outcomes now, I think one of the important things to think about is that these patients, interestingly, who the time from ADT initiation to becoming, really CRPC in a treatment intensification type era was 50% of the population was less than or equal to 12 months, going from ADT start to becoming CRPC. And I think there's some learnings out from that, which I'm sure we'll get to. But really the take-home point, I think, from the primary endpoint of PFS, almost 4 years of median follow-up. The control arm of abiraterone performed at around 9 or 10 months. And the intervention arm of Cabazi plus abiraterone was around 15 months. So that was improved. Hazard ratio 0.73, p-value 0.049. A lot of subgroups seem to benefit. And really ultimately not powered to really answer OS, but it was at least presented and reported and showed that, there was really no difference in survival. However, I think PFS was improved. I mean, a couple of things that we wanted to see on safety. Cabazitaxel at 25 milligram per meter squared, really should have had G-CSF, or there's comments about could you have gotten away with 20 milligram per meter squared. The other thing really I think to take away was that, although this isn't really a contemporary trial anymore, dosi alone for treatment intensification with ADT is not recommended. I think there is a story here that for patients who unfortunately at the start of MCSPC got ADT and progressed within 1 year, whatever the intensification is, whether it's ARAT or ARAT plus chemo, and we have these patients in our clinic, I think clearly we need to have better subsequent options for them. To me, the parallel to current era, when we do have patients that get ADT plus dosi plus, let's say, darolutamide is kind of an ARASENS triple therapy. For those men that we see progressing within 1 year, I think it's clear that we need something better. And it's possible that subsequent monotherapy like cabazitaxel, although an option, these are already in men who inherently have progressed on essentially 2 other good drugs like an ARPI and dosi already. So I think we need to do better. I think authors fully admit that while anticipated, this isn't going to change what you and I do in clinic, because if you're seeing these men, you're largely looking at thinking about ARPI for them now.
Yeah, I think, conceptually, it's a nice idea to be able to show that you can combine the different mechanisms of action. I think, in the clinical trial space, we always think about, what's our third line, what's our fourth line, what's our fifth line option. When you look at real world data, there's pretty good evidence that our fall off is pretty fast, right? First line to second line therapy, we lose like half of our patients. Second to third, we lose half of the rest. And so if we have multiple mechanisms of action we can offer our patients conceptually, especially in those poor risk subset you're talking about, the notion of combination therapy, I think, is like an appealing idea. And this really supports not necessarily this specific indication or even this treatment paradigm, but just that notion that when you're identifying the bad patients, we have maybe relatively limited windows of opportunity to offer them therapy, and getting multiple lines of therapy or multiple mechanisms of action in a timely way is a really important idea. And
I agree with you. And I think the field is even moving sooner in the MCSPC setting to, really see that dichotomy we see in clinic, which is somebody gets MCSPC treatment, doesn't get an undetectable or a PSA less than, let's say, 0.2 at 6, 9, or 12 months. Instead of waiting for that progression, maybe we should add something then. So that's kind of a shout out for the triple switch CCTG trial. And then what about the other part of the road, the patients who got treatment for MCSPC and have an exquisite biochemical response early? Could we look at treatment de-escalation? So I actually think more than, as you say, these 2 interventions and the way it's done, I think it just tells us we're seeing some unfortunate early progressors and some of those who are very privileged to have exquisite long-term biochemical response. So hopefully the future trials will look at answering those in either way. So, that really covers, I think the key late breakings that we saw up front.
Absolutely. And I think, the probably top of mind in prostate is lutetium PSMA. That's, I think, where everyone's interest lies, or certainly radioligand therapy. And we saw some updated data from PSMA-4. You want to walk us through what Dr. Fizazi presented?
Yeah, no, and again, it's a nice update. Again, just to remind everyone, this was a phase 3 randomized open label study. It did allow crossover. These patients, again, were receiving PSMA, lutetium-617, or the ARPI change. I think much has been made about the control arm in this trial, but really essentially what we did see was an updated endpoints of clinical data. So what we found is that the primary endpoint having already been met at primary, we saw a secondary interim analysis, medians of about 12 versus 6 months, hazard ratio in the 0.4 range, positive study at both endpoints. A key secondary endpoint was overall survival. Now, importantly, as mentioned, this had a crossover. So this meant that the patients in the control arm who could have gone the ARPI change and then crossed over, about 57% of those patients crossed over. In the intervention arm, the patients who got treated with lutetium, about 3/4, right? 77% of patients eligible crossed over. So this makes looking at overall survival, which is the totality of the patient's lifespan, difficult to tease out. But for what it's worth, the hazard ratio, which started above 1, is now down to 0.98. Curves are essentially overlapping with last minimum follow-up and all the censoring that comes with that. But, maybe there's something migrating, I think, accepting that PFS, which is really that important primary endpoint, was met. We did see some quality of life data. Maybe do you want to take us through the quality of life? Again, this was realizing the limitations of all these surveys, which we may not be able to fully unpack today. But what was your takeaway about the quality of life that was really the main part of the presentation?
Totally. And I think it's important to contextualize, right? We've got RPFS data showing that this disease is not progressing, at least radiologically. And the OS data, which when you interpret it in the context of the crossover you just talked about, essentially just means we're asking, what is the benefit of giving this treatment earlier versus later, right? We're not saying at all versus never. When we think about the crossover high rates, we're talking about, is there an additional benefit to giving the patients the lutetium earlier on rather than at the time of progression, essentially MCSPC first line MCRPC versus second line MCRPC. And that impacts, I think, how you interpret the health-related quality of life data, because even in spite of not getting an OS benefit, we are seeing that when you give that lutetium PSMA earlier, give it at that first line MCRPC, post-ARAT, pre-chemo, you get an improvement in predominantly pain-related scores, and you're holding patients about 3 to 4 months longer before pain progression. And that's, I think, a meaningful difference for people. That's, fits in the context of our scan intervals, and really, I think gives us, a kind of delta that is meaningful to our patients and meaningful to us as physicians. And knowing we have that option, I think is beneficial and tells us that we don't want to wait till the absolute end of the line to use this drug. If we use it a bit sooner, we can probably get that symptomatic benefit. When we think about vision was very late in the game. And this is showing that using it earlier, we can get more bang for our buck out of the treatment approach.
So Chris, a patient comes to you, you've treated them with an ARPI, they're progressing, they're a PSMA4 type patient. As of our recording today, they ask you about lutetium access.
Yeah, so there's 2 levels to this, because we're talking about the PSMA4 indication. The straight up answer is we do not have approval, period. And so access is a question beyond approval. But even when we think where we do have approval, right, we can think about the vision approval, we still don't really have access.
In Canada, and there's going to be a disparity around the world, right? Some places, US and others are racing ahead. Belgium, France, have lutetium access, gaining experience, patients are benefiting. We're talking about PSMA4, but as you say, we don't even at this point have reimbursement and access in Canada, despite a positive clinical analysis. So, I bring this up because I think we've talked about this offline and all weekend, that it's nice to analyze this data, but there needs to be some advocacy to try and push this through. I mean, do you think it's hype? Do you think we really do want access? Do we want it just in a vision setting, PSMA4 setting? Do we want unrestricted? I mean, kind of dream board, what would you like tomorrow for our patients?
Yeah, I mean, I take a bit of a health policy perspective. I think you can look at this from a patient level, a physician level, a system level, and your conclusions may differ a little bit depending on which level you're looking at. But I think one of the takeaways I took from the PSMA4 data we saw this weekend is that using this drug earlier is probably going to get more benefit for our patients. And so the notion of waiting till end of the line may really limit our opportunities to benefit from the use of this approach. We already alluded to the fact that many patients never get to third, fourth, fifth line therapies. And so I think if we want to maximize the benefit for our patients, we want to see this earlier. The more mechanisms of action we have available, I think the more opportunities we have to benefit our patients. It's not going to be for everyone. Obviously, the inclusion criteria into both these trials depended on PSMA imaging and eligibility. That's probably in the range of like 80+% of patients are going to have the appropriate PSMA-based findings. And even then, I think there's opportunities to find subsets of patients who are going to drive more or less benefit from radioligand approaches. But certainly, you want to be at the table. You want to be able to have these discussions and think about, selecting patients as opposed to the status we are today, where it's something we know other people are getting and we just can't offer.
Yeah, and for those listening and watching from a Canadian context, Health Canada approval in that vision setting, a CADTH or a Canadian Drug Agency positive clinical review, and now it's up for negotiation. So hopefully by the time we finish recording this, we'll have some better answers. But I do think, big picture is this field is moving fast. There will be a risk of greater inequity across many countries, not just the underserved populations, but also Western world if you don't have access. So the main point of this PSMA4 presentation was quality of life. Let's put a kind of a bow on the quality of life. Anything else you saw that we saw together at the orals from a quality of life that we can summarize here?
Yeah, so I think there's, we're talking about quality of life data in MCRPC and PSMA4. There's also quality of life updates from 2 trials in high-risk biochemical recurrence. So we have Presto and Embark. Each of these were presented previously, have been published. And so just to summarize, Embark looked at the use of enzalutamide with or without leuprolide in patients with high-risk biochemical recurrence after maximal local therapy. Presto took a similar approach. They used either ADT alone, ADT with apalutamide, or ADT with apalutamide and abiraterone. The studies had a little bit different oncologic endpoints. Embark looking at MFS, Presto looking at PSA-based progression-free survival, each showing a benefit from the oncologic perspective. And the question that arose in the 2 abstracts we saw this weekend was really about what's the quality of life effects. And I think there are really important takeaways here for urologists and for radiation oncologists who treat localized disease. And I think the first one I want to start with comes from Presto. And so Presto, as you recall, had ADT alone, which I think all urologists and radiation oncologists are comfortable prescribing, ADT plus apalutamide, and ADT plus apalutamide and abiraterone. And we know that initiating ADT comes with some toxicity. There's hot flashes, there's mood effects, there's fatigue. But the big takeaway over the year of therapy that patients got on Presto is that the addition of the ARPIs didn't meaningfully affect the toxicity or the patient reported burden of therapy. So in terms of counseling and managing your patients, I think if you're comfortable prescribing ADT and managing its toxicity, we shouldn't expect, based on these prospective data, that your patients are going to feel a substantially larger burden of therapy when you add the ARPI. And I think that's a really important takeaway as we consider the changing landscape of localized prostate cancer, right? We've got Proteus and Atlas coming out soon. We're looking at adding these same agents in the treatment of localized high-risk disease before recurrence. This is going to become part of the treatment paradigms in localized disease. And either we're going to need to do a lot of sharing of patients with medical oncologists, or those of us who treat localized disease are going to have to get comfortable giving these drugs.
Yeah, I mean, I think we could have a separate podcast on that, but I agree. If our scope of practice and the context in which we're treating patients is expanding, then I think all of us need to expand, is my view. And, we certainly are fortunate in centers where a variety of prescribers outside of medical oncologists are happy giving these pills. But it's good to know at least we haven't degraded quality of life too much. I mean, we could almost wonder if our current quality of life tools are good for very sick, very advanced disease patients. But in those who are doing well, are our quality of life tools actually capturing things? Because if they're not, then whatever outcomes we get aren't really actually assessing the patient. But for what it's worth, at least with what we have now, that's it. Anything else from the quality of life piece?
Yeah, so I think the flip side is we go to the EMBARK data, right? So EMBARK, importantly, at 37 weeks, if you had a good PSA response, you got to come off therapy. And so this fits with another sort of Canadian notion of intermittent ADT, right? Stopping therapy with the goal of trying to preserve quality of life. And I think the interesting takeaway from the EMBARK presentation from Steve Friedland is that stopping therapy didn't really have meaningful improvements in the patient-reported outcomes. And that's maybe not surprising when you consider their patient-reported outcome data from initiating therapy, published back in the fall, really showed that there wasn't harms to quality of life when you started the intensified therapy. So why would we expect it to improve when we take it away when it never got worse in the first place? But it does make us think, maybe a little bit critically about that value of treatment discontinuation, knowing that nearly all patients are going to need to resume their therapy. If we're not protecting quality of life in the short term, we have to maybe think about what we're trying to achieve with that treatment holiday.
Yeah, no, I think it's really important. And as we try and wrap up the prostate cancer session, we'll maybe highlight, and how can we not, blood biomarkers and prostate cancer, all the rage. Thought I'd give a little plug to a therapy analysis. So again, this was a phase 2 lutetium PSMA versus cabazitaxel. Great work led by Alex White and others looking at ctDNA at baseline and at 12 weeks and then at PD. And very, in a nutshell, this is the type of blood biomarker that's looking at targeting, the sequencing introns and exons. Also analyzing white blood cells too, because we need to account for things like a CHIP or clonal hematopoiesis expansion. And so really the fraction of circulating tumor DNA over the cell-free DNA that we have in our blood was kind of studied and analyzed. And, it was found that if you use a percentage of 2%, let's say for saying this presence is there, more than 80% of men in that study had that. Interestingly, PSMA SUV mean appeared to have a negative relationship with ctDNA, so a high fraction of the circulating tumor fraction above 30%. It looked like they had the lowest SUV mean. So I think it's curious to see. Obviously, there might be more heterogeneity or more differentiation. How do we understand this? But the lutetium PSMA activity appeared to be greater in patients who had lower fractions of ctDNA, or the PSA 50s, PSA 90s, improved progression-free survival also in lutetium versus taxane, understanding this, kind of genomic interplay here. So it looks like ctDNA is independently associated with PFS. Really cool work. We're going to try and understand this beyond just the fraction, but having genomics, right? That the granularity within. So I think that'll be really interesting. And again, we're really proud of the work that is done in Canada and elsewhere in trying to understand genomics here. So as we wrap up this ASCO weekend and our prostate cancer review, I think it'd be a nice time to just thank our viewers and listeners out there, many of whom have come up to us kind of unsolicited and stopped us and told them how much they've enjoyed our podcast, really, that started at GU ASCO and continues to grow. So really to all of you out there who have supported and sent us kind messages and words, we just wanted to thank all of you for your support. And we're, certainly learning and growing along the way.
Absolutely. We appreciate your feedback, your thoughts, your input, and any guidance you have. So in that vein, if you have feedback for us on either what you've heard around ASCO or future directions and things you'd like to have us cover, please reach out or leave comments on our videos. Rate, review, and subscribe so that we have your input and your feedback. And until next time, I want to thank you for listening and sign off on behalf of my co-host, Ali Khan Lalani. Thanks for listening to the VO and GU.